Okay, hello. So this is Medicine Simplified. Today we are going to do the chapter the lung and specifically focusing on the atelectasis. The topic that we would be covering is first it would be about the introduction, this part, and then we will study about the obstructive atelectasis. So let's start from the introduction that is mentioned in the book. So, embryology of the respiratory system. It develops from the ventral wall of foregut. As you can see in this picture, you can refer this picture for your information. The formation is basically midline trachea, and then there is formation of two lung buds forming the lobar bronchi. Then this lobes are divided into right and the left lung. There are basically in the right lung we have three lobes, and in the left lung we'll have two lobes. The clinical correlation that is mentioned is if any foreign body enters into the lung through your trachea, it would more likely enter the right main bronchus because it is wider and vertical. Now let's talk about the branching order of the airway. So we have trachea, main bronchi, lobar bronchi, segmental bronchi, bronchioles, terminal bronchioles, echinus, and then finally the alveoli. Now let's talk about the key features. The bronchi, it contains the cartilage and the mucus glands, whereas the bronchioles does not has cartilage and no submucosal glands. The terminal bronchioles are less than 2 mm in diameter. The echinus is a functional respiratory unit. So it is basically berry shaped cluster like unit of secretory cells, and it's also present in salivary mammary glands and acts as a structural unit in the lungs. Then talking about the pulmonary lobule, this is basically 3 to 5 terminal bronchioles with their echines. Now let's talk about the epithelium. So the general lining that is present in respiratory system is basically pseudostratified ciliated columnar epithelium. The exceptions are present in through vocal cords. It is stratified squamous epithelium. Let's talk about the cells that are present. We have ciliated cells that's responsible for mucus clearance. We have goblet cells, mucus production, club cells for protective secretions, ionocytes for CFTR regulation, that is basically fluid balance. Then we have neuroendocrine cells that secrete serotonin, bombesin, which is a neuroendocrine regulator. Now let's talk about the alveolar structure, which is responsible for gas exchange. So the components of alveolar septum are capillary network, which is the endothelium. Then we have the basement membrane, something like this. This is the endothelium and the basement membrane of the alveolar structure. And we have alveolar epithelium. There are pneumocytes that are present over here in this alveolar structure. We have type 1 and type 2. This is about 95% surface of it, and it's responsible for gas exchange. And then we have type 2, which is responsible for producing the surfactant and also responsible for repair. So basically it will prevent the collapse of the alveoli. Now let's talk about the atelectasis, that is obstructive or absorptive. We'll first go through the definition, causes, pathogenesis, then clinical findings and few questions, and then the last slide would be about the review of it. Now let's talk about the obstructive atelectasis. So the definition of this is basically there are key points that are mentioned that will take help from. So this is the normal lung, as you can see in the picture, and this is the collapsed lung. Now why did this thing happen? So if, as you can see in this picture, when there is a foreign body obstruction, such as tumor or mucus plug, it would lead to volume loss because there is no air that is passing into it. So, airway obstruction causes the loss of pre existing air. Now, this is because of the obstruction. Occurs, I said airway obstruction. Yes, because of airway obstruction, there will be loss of pre existing air in the peripheral alveoli, leading to alveolar collapse. Occurs when an obstruction prevents from reaching the distal airways. Since the volume is diminished, the mediastinum that's present would shift towards the lung that has atelectasis. Now this is I have marked with a star because this is an important point, because you can, when we'll go through the compressive atelectasis, we'll see a difference of mediastinum shift. So in obstructive, the mediastinum shifts towards the atelectatic lung. Now moving to the causes. So here I have mentioned few key points as well to remember. So obstruction of the bronchus by excessive secretion, that could be mucus or mucus plugs or exudates. Now what are exudates? Exudates are basically protein rich fluids that oozes out from the blood vessels where there is inflammation or injury. So this is known as exudates within the smaller bronchi. Now due to surgery, it could happen because of surgery, that is diminished respiratory movements will occur, which are results from post-operative pain. Second, we have foreign body aspirations, and it is mostly seen in children. Then we have bronchial asthma. Then we have bronchiectasis, which is basically a chronic lung okay chronic lung disease. Yeah, chronic lung disease. Then we have the chronic bronchitis, that is inflammation. Again, we have the chronic. Then we have intrabronchial tumor, which is basically a carcinoma, first sign of cancer. Now we have pathogenesis. Let's talk about the pathogenesis. Again, I have mentioned the keywords here. So, airway obstruction occurs by thick secretions, which prevents the air flow from reaching the alveoli, as I showed here. Now, the airway obstruction occurs in bronchi, segmental bronchi, or terminal bronchus. It could occur anywhere. After the obstruction, the circulating blood in the pulmonary capillaries absorbs the pre-existing air in the peripheral alveoli, which would lead to the collapse, alveolar collapse, and there would be an airless state within few hours. So that is why this is obstructive atelectasis. Now we'll talk about the common findings that are seen in this. So the most common things that we find here are fever, which is not related to infection. Then we have dyspnea, which is difficulty with breathing within the first 24 to 36 hours after surgery. Now, absence of breath sounds, can be seen, and also dullness to percussion. Now let's go through the questions. These are some few questions that I have put which was not mentioned before, so this is a nice way to remember some information. Which of the following is not a cause of obstructive atelectasis? Foreign object, tumor, mucus plug, or pneumothorax? I had mentioned all of these three, so the answer would be pneumothorax. Then we have on a chest radiograph. What is the key sign indicating a significant obstructive collapse? Is it increased lucency of the lung field, mediastinal shift away from the affected side, epicilateral shift to the mediastinum, or diaphragmatic flattening? So these are few questions that you can go through and you can mention in the comment, and we can see. I think I'll just mention it down in the description. Yeah, so now let's go through the review. We have obstructive atelectasis, which is equals to reabsorptive atelectasis. Then we see the mediastinal shift. This is an important point to remember, that as I've mentioned it over here, it occurs towards the side of the collapse. Causes could be mucus plug, tumor, body, foreign body. Management can be done, yes, this also you can remember as well. So incentive spirometry, I have seen one question where this was the answer. And bronchoscopy for the treatment, this is for prevention. Okay, that's all for this, and I'll come with the next topic, that is compressive. Then we'll go to the contraction one. Thank you so much.